Hello everyone, my name is Nina. I would like to welcome you all to the final presentation in Biochemistry 2. We did it! I chose the paper on thromboxane synthesis in health and disease, so without further ado, let's learn about some thromboxanes. So what I first wanted to do before I got into the actual paper was do a little review of what thromboxanes are, because I'm sure we've all forgotten chapter 21 by now. I don't blame you. I forgot it and I had to go back and look at it when I made this presentation. But what thromboxane is a derivative of arachidonic acid, and arachidonic acid is found in the plasma membrane of our platelets. And probably what you think of when you hear thromboxanes is thrombosis, which is a fancy word for blood clotting, and that's what it does. It is a vasoconstrictor, so it causes our blood vessels to shrink. You can see up here a normal blood vessel compared to a constricted one, and that helps with platelet activation and blood clotting. Here's the structures of the two different thromboxanes found in the body. They're both formed by cyclooxygenase. Well, first, I'll go into more detail in the next slide, but all you need to know about is that they come from the cyclooxygenase enzymes, and then thromboxane synthase, and they are a result of like injury to a blood vessel that would require clotting. So now what I wanted to do was go more in depth on the synthesis of thromboxane in the body, because that is what this paper is about. So first, let's say that you fall walking up the stairs in Old Main to come to this class, and then you trip and you scrape your knee. That will signal for phospholipase to release arachidonate from the plasma membrane of your platelets. Then that is where the cyclooxygenase enzymes get a hold of them and convert them into thromboxane A. There's a couple different pathways that it can do. So first, it actually gets turned into prostaglandin H2 right here, and then prostaglandin has a couple different ways it could go. It could go the PG synthases to make other prostaglandins for other purposes in the body, or it can go to thromboxane synthase. Well, it will be turned into thromboxane A. Thromboxane A has a pretty short half-life. It's unstable, so it will automatically hydrolyze and turn into thromboxane B, which has a longer half-life, and it hangs out for a little while in the bloodstream in your serum. So that is kind of a key aspect of the paper we're going to be looking at today, is that it hangs out and then it'll get degraded by beta oxidation or like a beta dehydrogenase pathway, and then it gets excreted in the urine. So we can look at either the serum concentration of thromboxane or the urinary metabolites that get excreted to have an index of COX activity or platelet activation or thromboxane synthesis, or all of the above. Another thing I wanted to note was the difference between the two cyclooxygenase enzymes and some of the inhibitors. So you have COX-1, which is constitutively expressed, meaning that it's always there. It's always being expressed. It's kind of a housekeeping enzyme, just waiting around, looking for a job to do. And then you have COX-2, which is inducible. So that would be if you fell and scraped your knee. You're not, I hope you're not falling and scraping your knee all the time. COX-2 would be induced in that case. It's also in a couple of, like your kidneys, it's located there, or, things like childbirth, creating prostaglandins for smooth muscle contractions, that sort of thing. So that's the difference between the two COX enzymes. And then I wanted to talk about the inhibitors. So the first thing we have is NSAIDs. These would be things like ibuprofen, naproxen, and aspirin. They are non-selective, and they inhibit both COX-1 and COX-2 the same. They love them both. The only difference is aspirin is a suicide inhibitor, meaning that once it binds to cyclooxygenase, it's not going to let go. That enzyme is basically toast. Versus like naproxen and ibuprofen are reversible inhibitors, meaning they will let go, once they've done what they're supposed to do. And then you have selective cyclooxygenase inhibitors, COX-IBs, are selective for COX-2. I think the only drug available in the market in the US is celecoxib, COX-2 inhibitor. But yes, those are the differences in the inhibitors and the enzymes themselves. I just wanted to talk about the pathways. So now that you guys are basically all pros at thromboxane synthesis and inhibition, I wanted to introduce the paper. The title of the paper is Measurement of Thromboxane Biosynthesis in Health and Disease. And the gist of it is that thromboxane A is unstable, like I just said, and thromboxanes have a role in lots of blood clotting diseases like atherothrombosis, inflammation, ischemic stroke, that sort of thing. So if we are able to look at the synthesis of thromboxane, then we can look at its activity in these diseases. So this is a paper about papers. It's like a literature study a little bit. So they were looking at the experiments of other people who were doing things like looking at urinary thromboxane metabolites or thromboxane concentration in the blood serum, both in healthy people and diseased people. This would allow them to look at, platelet activation in disease and cyclooxygenase inhibition in disease. So that was the basis of this paper. So before we go any further, I thought now might be a good time to have a break, have a Kit Kat, and answer a question. I want you guys to look at arachidonic acid. You can pause it here and go back in the lecture slides if you need to, or look at the class slides. It's an omega-6 polyunsaturated fatty acid that we synthesize from precursors that we have to get from somewhere else. So I was wondering, are there any diet changes that you could make that would reduce the synthesis of arachidonate in your body? So here's the first section of the paper where they talk about using urinary metabolites as a way to look at thromboxane implications in health and disease. What they were doing here is taking thromboxane B and infusing it into healthy patients or subjects. And then they were measuring the excretion of thromboxane metabolites in their urine to look at how it is disposed in the body, basically how long it stays. And what they found was that the excretion of these urinary metabolites was always independent of the infusion. So it didn't matter at what rate or how much thromboxane B they injected, it was always gotten rid of at the same rate. So this suggested that thromboxane A is hydrolyzed to thromboxane B, which we already knew because we're smarty pants, before it's degraded via beta oxidation into its metabolites. They also found that aspirin and other NSAIDs reduced these metabolites by 80%, so that's pretty significant. So they decided that aspirin could be used to look at thrombotic health events, blood clotting. And basically what you should get from this section is that thromboxane B is a good way to measure the synthesis of thromboxane A, which is what we really want to look at. And this picture here I thought was good because here was the excretion of the urinary metabolites in healthy people, but compare that to somebody who has peripheral artery disease. Look how much of these metabolites they're excreting. Or people with unstable angina, that's chest pain related to the blockage of a coronary artery in your heart. They're excreting a lot of these metabolites, so that gives you a hint as to, hey, maybe these thromboxanes are playing a part in this disease. Here's the second part of the paper where they talk about looking at serum thromboxane concentration to get an idea of cyclooxygenase activity. The amount of thromboxane in your serum gives you an idea of the thromboxane A synthesis. The first step is cyclooxygenase enzymes, so that's what they were looking at. What they found is that there is an exponential relationship between cyclooxygenase inhibition and platelet activation. I mean, look at how much you have to inhibit cyclooxygenase before you actually get an effect on platelet activation. I mean, it's all the way over here. And they found that cyclooxygenase has to be suppressed around 97% before you actually start to see any platelet suppression. So that made them wonder, hey, maybe traditional NSAIDs don't work as well as aspirin. And I was wondering, can you guys figure out why? That's not a question, but the reason why is because aspirin is a suicide inhibitor, and they basically take that enzyme out of circulation. NSAIDs are reversible, so they'll go away after a certain amount of time. But this was the relationship of COX inhibition and platelet activation inhibition. It's time for our second question. This kind of relates to the slide before the previous one, so if you need to pause and go back, you're more than welcome to. I want you guys to tell me why patients who have blood clotting complications like ischemic stroke and unstable angina have more of these urinary metabolites. And then I also want you to tell me why low doses of aspirin daily can help reduce some of those complications. So the last thing I wanted to talk about that I thought was kind of interesting was that body weight has an effect on using aspirin as a cyclooxygenase inhibitor. So lots of patients who have complications relating to their weight, such as diabetes mellitus or metabolic syndrome, they have issues with blood clotting as well, things like stroke, heart attack, thrombosis, that sort of thing. So what they found was that low aspirin dosage is really only effective in people weighing less than 70 kilograms. And you can see on the graph over here on both BMI and body weight, the lower doses are really only effective on people of lower body weight. And the reason for that is because aspirin is a lipophilic drug. So for an obese individual who might have more fat deposits on their body, that would make the availability of aspirin lower. So there would not be as much aspirin available where it needs to work, like say in the heart, where a blood clot might be. So I just thought that was a very interesting application of this concept. So here's where they concluded and talked about the clinical implications of this paper. Number one, the excretion of thromboxane metabolites in the urine is a really good way to look at platelet activation, cyclooxygenase activation or inhibition, and then also the synthesis of thromboxanes themselves. And it's non-invasive, which is also a plus because nobody likes a doctor all up in their face. The second thing is that these experiments have really helped us look at antiplatelet therapy and aspirin's role in health and disease, and maybe looking at some alternatives for platelet therapy. And then as we've seen with the last slide, depending on people's health conditions, whether they have like excessive platelet turnover or high BMI, personalized dosage of that aspirin might be necessary to control platelet activation and thusly thromboxane synthesis. These are my references. I really only use the textbook and the lecture slides in the paper, and then the memes were made by me, myself, and I. I hope you enjoyed them. All right, I want you to stand up, give yourself a pat on the back. Go get a little sweet treat. You deserve it because this was the last presentation. It is done. I want to thank you all for your time and your attention, and have a great summer break, everyone. I'll see you in the final.